Now, imagine there is a traffic jam. Your sugar can't get into your cells and just keeps building up. That's diabetes. This leads to high levels of glucose in your blood and not enough of it in your cells. And remember that your cells need glucose as a source of energy. So not letting the glucose enter means that the cells starve for energy despite having glucose right on their doorstep. Welcome back to the Post Medics. Today we are going deep into diabetes mellitus, what it is, how it happens, why it matters, and how we can manage and prevent it. Diabetes mellitus, often simply called diabetes, is a chronic metabolic disease where the body cannot regulate blood glucose properly. Glucose is the primary energy source for most cells. In general, the body controls how much glucose is in the blood relative to how much it gets into the cells with two hormones, insulin and glucagon. Insulin is used to reduce blood glucose levels, and glucagon is used to increase blood glucose levels. Both of these hormones are produced by a cluster of cells in the pancreas called islets of Langerhans. Insulin is secreted by beta cells in the center of the islets, and glucagon is secreted by alpha cells in the periphery of the islet. Normally, after you eat, glucose enters your bloodstream, signaling your pancreas to release insulin. Insulin reduces the amount of glucose in the blood by binding to insulin receptors embedded in the cell membrane of various insulin responsive tissues like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing glucose transporter to be moved. The word diabetes comes from Greek word meaning to pass through, because people with untreated diabetes lose lots of water and sugar in urine. Mellitus means sweet like honey. Early civilizations like the Greeks, Egyptians, and Indians recognized the sweet urine in this condition. Fast forward to 1889, scientists discovered that pancreas plays a key role. Then in 1922, Banton, Best, and Collip isolated insulin, transforming diabetes from a fatal illness into a treatable condition. Types of diabetes. There are two main types of diabetes, type 1 and type 2. Though there are other types, the main difference between them is the underlying mechanism that causes the blood glucose to rise. Let's start with type 1 diabetes, which is usually 10% of the cases. Type 1 diabetes mellitus develops as a result of a type 4 hypersensitivity reaction, which is also referred to as a cell-mediated immune response. In this condition, the body's T lymphocytes mistakenly identify the pancreatic beta cells as foreign and initiate an immune attack against them. This makes type 1 diabetes a classic autoimmune disease, where insulin-producing beta cells in the pancreas are progressively destroyed. Several autoantibodies are commonly associated with this process, including anti-GAD antibodies, that is, anti-glutamic acid decarboxylase, which targets the enzyme glutamic acid decarboxylase, and islet cell antibodies, both of which serve as diagnostic markers. As beta cells are destroyed, insulin production declines. Without insulin, glucose is unable to enter body cells efficiently, leading to elevated blood glucose levels. Type 1 diabetes most often presents during childhood or adolescence, though it can occur at any age. Because the body can no longer produce insulin, individuals with type 1 diabetes require lifelong daily insulin therapy. The underlying mechanism involves a breakdown in self-tolerance, a normal immune process that eliminates T cells capable of reacting against the body's own tissues. In type 1 diabetes, a genetic predisposition leads to failure of self-tolerance in T cells that recognize beta cell antigens. These autoreactive T cells are then allowed to persist, recruit additional immune cells, and orchestrate targeted immune response against pancreatic beta cells. One of the most important genetic contributors involves the human leukocyte antigen system, or the HLA system, particularly HLA-DR3 and HLA-DR4. These genes are located on chromosome 6 and encode components of the major histocompatibility complex, that's MHC. MHC molecules function as antigen-presenting platforms that allow immune cells to distinguish self from non-self. While many individuals with type 1 diabetes share HLA-DR3 or HLA-DR4, possessing these genes alone is not sufficient to cause the disease, highlighting the role of environmental triggers. Beta cell destruction typically begins early in life, but clinical symptoms may not appear until up to 90% of beta cells have been lost. Once insulin deficiency becomes severe, characteristic symptoms of uncontrolled diabetes emerge. These include glycosuria, polyphagia, polyuria, and polydipsia, known as the three Ps. Despite abundant glucose in the bloodstream, cells are unable to utilize it for energy. As a result, the body enters a catabolic state, breaking down fat through lipolysis and muscle protein for fuel. This leads to weight loss and intense hunger, known as polyphagia. The excess glucose filtered by the kidney spills into the urine, a process called glycosuria. Because glucose is osmotically active, it draws water with it, resulting in increased urination or polyuria. Excessive fluid loss then leads to dehydration and intense thirst, referred to as polydipsia. Although individuals with type 1 diabetes cannot produce insulin, their cells remain responsive to it. Therefore, treatment relies on exogenous insulin administration to regulate blood glucose and allow cells to properly utilize glucose. A severe and potentially life-threatening complication of type 1 diabetes is diabetic ketoacidosis, simply known as DKA. In the absence of insulin, increased lipolysis releases free fatty acids, which are transported to the liver and converted into ketone bodies, including acetoacetic acid and beta-hydroxybutyric acid. Acetoacetic acid is a true keto acid, while beta-hydroxybutyric acid, though classified as a ketone body, lacks a ketone group due to reduction. Ketone bodies serve as an alternative energy source, but significantly lower blood pH, producing a high anion gap metabolic acidosis. As acidosis worsens, patients develop Kussmaul respiration, characterized by deep, labored breathing that helps eliminate carbon dioxide and partially correct blood pH. Acidosis also disrupts potassium balance. Hydrogen ions shift into cells in exchange for the potassium, raising extracellular potassium levels. Additionally, insulin normally stimulates the sodium-potassium ATPase. Without insulin, potassium remains outside cells. These mechanisms result in hyperkalemia, although total body potassium stores become depleted over time due to urinary losses. DKA may occur even in patients already receiving insulin, particularly during periods of physiological stress such as infection. Stress hormones like epinephrine increase glucagon release, tipping the insulin-glucagon balance toward hyperglycemia. This cascade leads to worsening hyperglycemia, osmotic diuresis, dehydration, ketone production, and acidosis. Ketone bodies eventually degrade into acetone, which is exhaled through the lungs and produces the characteristic fruity odor on the breath. Beyond this, decay commonly causes nausea, vomiting, altered mental status, and in severe cases, cerebral edema. Management of diabetic ketoacidosis involves aggressive intravenous fluid resuscitation, insulin therapy, and careful electrolyte replacement, particularly potassium. Together, these interventions correct dehydration, lower glucose levels, halt ketone production, and restore metabolic balance. Let's talk about type 2 diabetes, which is about 90% of the cases, is the most common and is often linked to insulin resistance. When the body makes insulin, but the cells don't respond well to it. So it's strongly associated with metabolic syndrome defined by greater or equal to 3 of waist circumference, triglyceride greater or equal to 150, decreased HDL blood pressure greater or equal to 130/85, fasting glucose greater or equal to 100. Adipose tissue releases adipokines and inflammatory cytokines, impairing insulin receptor signaling. The exact reason why cells don't respond in type 2 diabetes isn't fully understood. Essentially, the body's providing the normal amount of insulin, but the cells don't move their glucose transporters to their membrane in response, which, remember, is needed for glucose to get into the cell. These cells, therefore, they have insulin resistance. Some risk factors for insulin resistance are obesity, lack of exercise, and hypertension. And exact mechanisms are still being explored. For example, an excess of adipose tissue or fat is thought to cause the release of free fatty acids and so-called adipokines, which are signaling molecules that can cause inflammation, which seems related to insulin resistance. However, many people that are obese are not diabetic, so genetic factors probably play a major role as well. In type 2 diabetes, since tissue don't respond as well to normal levels of insulin, the body ends up producing more insulin in order to get the same effects and move glucose out of the body. They do this through beta cell hyperplasia, that's an increased number of beta cells, and beta cell hypertrophy, where they actually grow in size, or in this attempt to pump out more insulin. This works for a while, and by keeping insulin levels higher than normal, blood glucose levels can be kept normal, called normoglycemia. Now, along with insulin, beta cells also secrete islet amyloid propylpeptide, or amylin. So while beta cells are cranking out insulin, they also secrete an increased amount of amylin. Over time, amylin builds up and aggregates in the islets. This beta cell compensation, though isn't sustainable, over time those maxed out beta cells get exhausted and they become dysfunctional and undergo hypertrophy and get smaller, as well as hypoplasia and die off. As beta cells are lost and insulin levels decrease, glucose levels in the blood starts to increase and patients develop hypoglycemia, which leads to similar clinical signs that were mentioned before, like polyphagia, glycosuria, polyuria, and polydipsia. But unlike type 1 diabetes, there is generally some circulating insulin in type 2 diabetes from the beta cells that are trying to compensate for the insulin resistance. Over time, the pancreas can't keep up with the demand for insulin. It's often associated with obesity, sedentary lifestyle, and genetic factors. Let's talk about another type, which is gestational diabetes. It occurs during pregnancy. It may resolve after childbirth, but increases the risk of type 2 diabetes later in life. The cause is thought to be related to pregnancy hormones that interfere with insulin's action or insulin receptors. Why gestational diabetes occurs? So during pregnancy, the placenta produces several hormones such as human placenta lactogen, estrogen, progesterone, cortisol, and placenta growth hormone. These hormones are essential for fetal growth and development. However, they also have a significant metabolic effect on the mother. These pregnancy hormones reduce the sensitivity of insulin receptors on body cells, a condition known as insulin resistance. When insulin binds poorly to its receptors, glucose is unable to enter cells efficiently, leading to a rise in blood glucose levels. To compensate, the mother's pancreas attempts to produce more insulin. In many women, this increased insulin production is sufficient to overcome the insulin resistance. However, in some women, the pancreas cannot produce enough insulin to meet the increased demand. When this happens, blood glucose levels rise, resulting in gestational diabetes. Let's talk about drug-induced diabetes. Also, sometimes people can develop drug-induced diabetes, which is where medications have side effects that tend to increase blood glucose levels. The mechanism for both of these is thought to be related to insulin resistance, like type 2 diabetes, rather than an autoimmune destruction process, as in type 1 diabetes. Drug-induced diabetes refers to a condition in which certain medications cause a persistent rise in blood glucose level, leading to the development of diabetes in individuals who previously had normal or borderline glucose control. In some cases, the diabetes may resolve after stopping the medication, while in others, it may unmask an underlying tendency toward type 2 diabetes, making the condition permanent. Most drugs responsible for this condition interfere with insulin's ability to act on its receptors or disrupt normal glucose metabolism. As a result, glucose cannot effectively enter body cells, leading to elevated blood glucose levels. There is another form of diabetes called monogenic diabetes. Monogenic diabetes refers to a group of diabetic disorders caused by a mutation in a single gene. This is very different from type 1 diabetes, which is autoimmune, and type 2 diabetes, which is polygenic and strongly influenced by lifestyle and environment. Even though monogenic diabetes accounts for only about 1 to 5% of all diabetes cases, it's often misdiagnosed, and that misdiagnosis can completely change how a patient is treated. What makes monogenic diabetes unique? The key feature of monogenic diabetes is that the problem lies in how insulin is produced or secreted, not in insulin resistance or immune destruction. Most of the genes involved are critical for pancreatic beta cell development, glucose sensing inside beta cells, regulation of insulin gene expression. Because this is a genetic condition, it often runs strongly in families. It typically follows an autosomal dominant inheritance pattern. Multiple generations may be affected. There are two major categories of monogenic diabetes. These are neonatal diabetes and maturity onset diabetes of the young, which is referred to as MODY. Let's look at this neonatal diabetes. Neonatal diabetes presents very early in life, usually before 6 months of age. This is an important clinical clue because autoimmune type 1 diabetes almost never present this early. Why neonatal diabetes happens? In neonatal diabetes, mutations impair beta cell development, insulin secretion, or potassium channel function in beta cells. Maturity onset diabetes of the young, which is the second form. Despite the name, it's not type 2 diabetes. Key characteristics include onset usually before age 25, strong family history across generations, non-obese patients, no autoimmune markers, preserved insulin production, C-peptide is present. MODY occurs due to mutations in genes that regulate beta cell function, not insulin sensitivity. Signs and symptoms of diabetes. Common symptoms include polyuria, that's frequent urination, polydipsia, excess thirst, polyphagia, increased hunger, unexplained weight loss, fatigue, blurred vision, slow wound healing. Some people, particularly with type 2, may have no symptoms at first. The prevalence and incidence. Worldwide, about 1 in 10 adults has diabetes. The number is rising, especially in low and middle income countries. Many people don't even know they have it, especially in early stages. Causes and the risk factors. So, risk factors in type 1 include family history, autoimmune triggers, and genetic markers. In type 2, there's also family history, obesity and physical inactivity. Age. Risk increases with increasing age. Poor diet, history of gestational diabetes, ethnicities have higher risk. Diagnosis. We may do a fasting blood glucose test. So diagnosing type 1 or type 2 diabetes is done by getting a sense for how much glucose is floating around in the blood. Very commonly, a fasting glucose test is taken where the patient doesn't eat or drink except water for 8 hours and has their blood tested for glucose levels. Levels of 110 milligrams per deciliter to 125 milligrams per deciliter indicates pre-diabetes, and 126 milligrams per deciliter or higher indicates diabetes. A non-fasting or random glucose test can be done anytime with 200 milligrams per deciliter or higher being a red flag for diabetes. Another test is called an oral glucose tolerance test, where a person is given glucose and then a blood sample are taken at time intervals to figure out how well it being cleared from the blood. The most important interval being 2 hours later. Levels of 140 milligrams per deciliter to 199 milligrams per deciliter indicates pre-diabetes, and 200 or above indicates diabetes. Another thing to know is that when blood glucose levels get high, the glucose can also stick to proteins that are floating around in the blood or in the cells. We do our HbA1c, that's average blood sugar over 3 months. This tests for the proportion of hemoglobin in red blood cells that has glucose stuck to it, called glycated hemoglobin. HbA1c levels of 5.7% to 6.4% indicates prediabetes, and 6.5% or higher indicates diabetes. This proportion of glycated hemoglobin doesn't change day to day, so it gives a sense for whether the blood glucose levels have been high over the past 2 to 3 months. Finally, we have the C-peptide test, which tests for a byproduct of insulin production. If the level of C-peptide is low or absent, it means the pancreas is no longer producing enough insulin and the glucose can't enter the cells. Complications. If left untreated, diabetes can lead to cardiovascular disease. Then in certain cases, there could be hyperglycemia. This is because insulin treatment comes with a risk of hypoglycemia, especially if insulin is taken without a meal. Symptoms of hypoglycemia can be mild, like weakness, hunger, shaking, but it can progress to loss of consciousness in severe cases. In mild cases, drinking juices or eating candy or sugar may be enough to bring blood sugar up. But in severe cases, intravenous glucose should be given as soon as possible. It can lead to nerve damage or neuropathy. It can lead to diabetic ketoacidosis. The most serious complications of type 1 diabetes is diabetic ketoacidosis. In DKA, lipolysis produces free fatty acids. The liver converts these into ketone bodies. Ketones include acetoacetic acid and beta-hydroxybutyric acid. These acids lower blood pH, leading to metabolic acidosis, which leads to Kussmaul respiration, which is deep and rapid breathing, fruity breath from acetone, hyperkalemia, despite total body potassium depletion, high anion gap, metabolic acidosis was also another cause, and then kidney failure, blindness, and then infections and amputations. We also have our HHS, which is hyperosmolar hyperglycemic state. So when levels of glucose are super high in the blood, water begins to leave the body cells and enter the blood vessels, leaving the cells relatively dry and shriveled rather than plump and juicy. Blood vessels that are full of water lead to increased urination and total body dehydration. This is a very serious situation because the dehydration of the body cells and in particular the brain can cause a number of symptoms, including mental status changes. In HHS, can sometimes see mild ketonemia and acidosis, but not to the extent that is seen in DKA. Let's look at the difference between DKA and HHS. So, DKA is commonly found in type 1 and HHS is commonly found in type 2. Ketones are usually present in DKA while it's minimal in HHS. pH is acidic in DKA, HHS is near normal. Glucose in DKA is greater or equal to 250, in HHS is greater or equal to 600. Onset of DKA is rapid, while that of HHS is gradual. Dehydration in DKA is moderate, and that of HHS is severe. Treatment of diabetes. So, with our pharmacological treatment, in the case of type 1 diabetes, we give lifelong insulin, basal bolus regimen. Then, in type 2 diabetes, we have lifestyle modification. We may give medications like metformin. We add second agents based on comorbidities. So, we have our GLP-1 agonists, our SGLT2 inhibitors, our DPP4 inhibitors. Diabetes management is lifelong, but with the right plan, complications are preventable. Prevention and public health. So promote healthy lifestyles, screen high-risk individuals, support policies that improve nutrition and activity, educate communities. In summary, diabetes is common, serious, but manageable and often preventable. Support our channel by subscribing and liking our videos. Thank you.